Welcome to the maintrac Online Forum 2026. My name is Mrs. Friste and I will be your moderator today. The topic is personalized oncology, circulating cancer cells before, during, and after therapy, presented by Professor Dr. Katharina Pachmann, founder and CEO of maintrac.
Hello, good evening. Today is the first online forum in 2026, and I would like to guide you to how the circulating cancer cell determination before, during, and after therapy can contribute to optimize personalized oncology. Cancer is one of the leading causes of death worldwide. In 2022, around 20 million new cancer cases were diagnosed globally. And according to the World Health Organization projections, the annual number of new cases could rise to over 35 million by 2050. And the most common cancers are breast cancer, lung cancer, colorectal cancer, prostate cancer, skin cancer, and stomach cancer. And here I will show you how it is believed that metastases develop. That is, tumor, when it gets vascularized, cells can detach from the primary tumor and get into the bloodstream. And these are called circulating tumor cells. And you can see here one cell has detached and it's growing. And this is in a distant site, so it's called metastasis. And it's assumed that metastases originate from circulating cancer stem cells, and I will go into this further then. Tumors are growing at very, very different times, and it takes about 25 doublings because a tumor becomes detectable. So if we have a model of a breast cancer, a rapidly growing tumor, it might be a doubling time from one cells. If it doubles once, one doubling per month, it takes about 2.5 years until the tumor becomes clinically detectable. So if a patient undergoes annual mammography screening, the tumor may not be detected, but 3 to 5 months after the mammogram, she palpates the tumor herself. This is an intravenous cancer. And if tumor cells had already disseminated and settled in distant tissue and grown at the same rate as the primary tumor, metastasis may develop again approximately 2 to 3 years after initial diagnosis. This is shown here. The blue dots, that's the primary tumor, which doubles at a time of 1 month. And at the time when the tumor is not detectable at all, the blood supply may set on, and this is about at cell number of 1 million cells, but the tumor is not detectable yet. But then, if the tumor is palpable and is removed by surgery, cells may have left the tumor already at this early time of blood supply. And if the metastases grow at the same rate as the primary tumor, then the metastasis may be detectable about 2 to 3 years after the diagnosis of the primary tumor. And we know that this is in effect shown in rapidly growing breast cancer. So, as I said, after 25 doublings, a tumor becomes detectable, but in a slow growing tumor, the doubling time may be 6 months, and then it takes 12.5 years from the single cell that had been mutated until the tumor becomes clinically detectable. And in this case, a patient who goes annual mammography screening, the tumor is detected. But if tumor cells have been previously, before detection, have disseminated and settled in distant tissue and grown at a rate comparable to the primary tumor, the metastasis may still remain undetectable even 10 years after the initial diagnosis. So the tumor size alone does not allow for determination of how long the tumor has been growing. And this is shown here. So again, the blue dots are the primary tumor at the size of 1 million cells. The vascularization starts, the dissemination can start, but even 10 years after the detection of the primary tumor by mammography, the metastasis will not be detectable, but even 10 years after the primary detection. The detection and the detection of metastasis is very strongly dependent on the tumor doubling time. Our aim is to look for these cells released, and it can be subsumed under liquid biopsy. Liquid biopsy is a minimally invasive diagnostic method, and it's based on the analysis of body fluids, mainly blood. And the tumors can release the following components into the bloodstreams. Tumor cells, we call them circulating epithelial tumor cells, or it's called also CTCs. It can be circulating tumor DNA, which is called ctDNA, or exosomes and other tumor-associated components. The maintrac analysis is a liquid biopsy, and this means that it's minimally invasive for detection, and we concentrate on viable circulating tumor cells in patients with an already confirmed diagnosis. But it enables assessment of therapy effectiveness, of chemotherapy, hormone therapy, or targeted therapy. And we show that it's able to early detect recurrence of the disease after completion of the therapy. How do we approach this? The tumor cells from epithelial tumors carry an antigen on their surface, the so-called EpCAM antigen, which is a sign of epithelial origin. And we have antibodies which are fluorochrome labeled, which can attach to the EpCAM molecule and make them visible in fluorescence light. This is applicable to all solid tumors. It's fast and reproducible, and it's performed in a laboratory which is accredited according to DIN and ISO 15189. So our approach is the following. You send us the samples with coagulated blood, like for blood cell count, and the only step we perform is the lysis of the red blood cells, because they 1,000-fold more than the white blood cells. Then there is a centrifugation step, and then we add the anti-fluorescent antibody to the white blood sediment. The cells are then distributed in the wells of ELISA plates, and the microscope automatically scans over these plates and shows us the cells, and we can quantify them and draw a trajectory of the numbers of tumor cells. There are 3 different sorts of cells: the living cells, which should have a nice nucleus but unstained because they are living. And on the left side, there are cells that are in the process of dying. This means the membrane becomes porous, and red fluorescent dye can enter into the nucleus, and this is a sign that the cells are in the process of dying. And the middle gallery, cells that are not really discriminable, and we eliminate these cells from the total cell count. On the right side, you can see that maintrac enables also the detection of circulating epithelial cells with minimal EpCAM expression. and that we can distinguish them from the undiscriminable cells and the dead cells. So what is the moment when circulating tumor cells should be determined? This may be before the treatment, that's the baseline, and we there determine the level of circulating tumor cells at that point. And we also can characterize these circulating tumor cells more clearly, and they can differ from the cells which are in the tumor itself. Then during treatment, we can dynamically assess the treatment response and also identify potential therapy failure. And in case of disease progression and suspected resistance, we can early detect the resistance mechanisms. We can test the sensitivity of these cells to different substances directly on these cells in the blood. And we can also analyze therapeutically relevant markers on these cells. After completion of therapy, we can follow the remnant minimal residual disease, and we can also early detect the possible recurrence of the disease. Do you have any questions at this time?
Yes, there are 3 questions. Is it expected that circulating tumor cell count stays high after known metastasis from breast tumor, or can it come down?
It not necessarily needs to stay high because the substances used for chemotherapy, for example, can meet the cells in blood at a higher concentration and can bring the numbers even down. But what we then often observe is an re-increase from cells, possibly from the tissues which are recirculating, and then we can see this precedes tumor metastasis.
Do you always see high tumor cell count in the case of metastasis?
If the metastases have not been treated, yes, we usually find high numbers. But if there's already been a treatment, then the numbers can be quite low. And only if the therapy stops, then the numbers come up again.
So I think you already answered the question, but I want to ask it anyway. How relevant is it to check the circulating tumor cells after known metastasis and surgery?
If the metastases have been removed by surgery, then it should be tested according to how fast cell numbers increased in about 2 to 6 month distance.
So another question, why EPCAM? Is there currently another marker available or possible as well?
There are a number of markers, but EPCAM is detected on the cell surface. Many other markers are only detectable inside the cells, and this means that we have to lyse the cells or fix the cells. This is something we do not want to do because we want to determine the living cells. So at the moment, EPCAM is the best marker on these living cells.
Should the testing of circulating cancer cells be combined with ctDNA testing?
We can't answer this question yet, but what we have so far seen is that the epithelial circulating tumor cells are more sensitive than ctDNA detection. And there was just recently several publications on the sensitivity of the ctDNA, and it seems not to be sensitive enough in early cancer. It can be used to follow metastatic tumor, but not early tumors. And that's the main area where you think the circulating tumor cells measuring is meaningful.
So please, Professor Dr. Bachmann, go on.